喂，哎呀，对啊，哎，好，好。
我们先放。
123，
加
123，123，123，OK 哦，声音 OK 哦。123，123，123，45678。你要关掉吗？
动动开着好。
丽珍姐，请问我是不是就在5分钟开始？因为其实他们刚来，然后正在说话，我这时候打断，不知道会不会。
还有5分钟是不是？那就让他去讲一下说，这个场次在5分钟后开始，会不会对署长不礼貌？
他们
不会，没关系，等一下下，再1分钟，就说等一下再3分钟。
Good afternoon, ladies and gentlemen. Welcome to the Global Health Forum in Section 9. The opening ceremony will start in 3 minutes. Thank you. Ladies and gentlemen, welcome to the Parallel Section 9, Acute Care for Elders in a Super-Aged Society, toward Age-Friendly Hospital. Let's welcome our moderator for the section, Professor Liang Gong Chen.
Thank you. Welcome back from your lunch, and I hope you can concentrate on this important session. I am Dr. Liang Gong Chen. I'm currently the professor of Aging and Health Research Center of National Yangming University, as well as the director for the Center for Geriatrics and Gerontology of Taipei Veteran General Hospital. And we've been working on geriatric services for many years, so we're very excited for this session, especially our distinguished guests from abroad to share some of their experiences with us. And most important of all, the Health Promotion Administration also launched a new ACE program in Taiwan. They were hoping to do, through this pilot program, we were able to really change the healthcare services for older people in Taiwan. In the past few years, Taiwan eventually has started that we call age-friendly hospital system. That has created a lot of different items for certificate for each hospitals in Taiwan that helped to build up the infrastructure and the process how hospitals seeing the older patients. But there is one thing that has not been achieved that needs this ACE program to achieve, which is many hospitals or the healthcare professional, they did not interpret the term friendly correctly. So they are thinking friendly is just being kind to older people. So some hospitals, they are very kind to all the senior patients, and they entertain them with enthusiasm. But when the patient is admitted, everything goes back to the usual track. So it does not really change the healthcare services, and that's not our purpose for this age-friendly service. So this year, Health Promotion Administration kick off the real good program to improve the acute care for the older patient, which is highly expected by us, the geriatricians and the other hospitals. They were hoping to make some change, some progress for this country. So this afternoon we're going to have three speakers. And everyone will share the experiences for 25 minutes, and you will not be kick off the stage if you run over time. It'll be fine. and then after all speakers, we're going to have some discussion. So let me welcome the first speaker is from Canada, Dr. Samir Sinha, and who is an expert geriatrician doing the inpatient care for the acute services for older patients. So let's welcome Dr. Sinha.
Yes.
Mm-hmm.
Perfect. Yes, perfect. Okay, well, thank you very much, Prof. Chen, and it's great to be able to kick off the this session talking a little bit about our what we call our ACE strategy, or our acute care for elders strategy, which is an approach that we've been developing in Canada, but really developing on years of expertise that many people have developed over time. And so really what I want to do to spend the next 30 minutes is really to focus on kind of what are some of the reasons why our current ways of delivering care are problematic and require this new elder-friendly approach. And then I'll talk a little bit about our acute care for elders strategy as a care model that can deliver better patient and system outcomes. And then finally, share a few lessons learned on advancing the care of older adults in a complex healthcare landscape. Now, as you heard, I come from Canada. And so, of course, if some of you haven't had the privilege and the pleasure of coming to Canada, you'll see that we probably have some very similar stories already. So right now, to understand that Canada's population is aging, and it's aging faster than Taiwan's at the moment. Right now, 17% of our population are what we call 65 or better. But like Taiwan, we are aging rapidly. We expect that our population by 2030 will have 1 in 4 Canadians, so 25% being 65 and older. But right now, our population 85 and older is set to quadruple in this time. And our fastest growing age group today are those people over 100. So we expect to have 50,000 people who are older than 100 in 2030. Now, we also know that older adults in Canada in our publicly funded systems account for 50% of our healthcare spending. And as that relates to hospitalizations, as we're talking about ACE in hospitals here in Taiwan, we know that this 17% of older Canadians represent 42% of all of our hospitalizations. So small proportion, but already a significant number of hospitalizations. And when it comes to the overall days in hospital, when you think about older adults spending time in hospital, they tend to stay longer in hospital than younger people. And so we know that currently about 60% of our overall bed days in Canada are accounted for by older adults. And this is in acute care settings. So now when you think about that, you realize that this is why many people are concerned that we have an aging population and already using so much of our hospital services that it's interesting that when you look at our hospitals in Canada, many of them don't say that geriatric care or care of older adults is their priority, right? Many of them talk about cancer or they talk about trauma, but they don't talk about geriatric care when that's the majority of the work that Canadian hospitals are performing. So when we think about older users of healthcare, it's also important to understand that not all older people are frail and needing to be in hospital. In fact, when you actually look at our data, and it's the same data in Canada as it would be in the US, as I'm sure it would be in Taiwan, we start realizing that when you look at the small proportion of older adults who are using hospital services, that really only a small proportion of older adults, so about 1 in 10, account for 2/3 of all healthcare spending related for older adults. And that's our data in Canada. It's the same in the United States, and it reminds us that many older adults are leading healthy and active lives, but there's a small proportion that are actually characterized by having a number of different health issues, but I'll talk a little bit more about that in a moment. So now we start thinking about older adults that we know, older adults that we might care for, and we start understanding why hospitals can actually be dangerous places and why they can actually fail older adults who need that care. And as Prof. Chen was talking about, it's great that the work already is making sure that we're nice to people, but being nice is one thing, making sure that we don't fail them in their care is a whole other issue. So an important piece of work was done by a gentleman called Walensky, a researcher back in 1995, who was working on something called the American Longitudinal Study on Aging. And he simply asked the question, how often do older Americans hang out in hospital? Because again, I showed you data, and you probably think that when you turn 65 in Canada, you sell your house and you go live in a hospital, right? But we know that in this data here, he looked at 7,000 Americans who are 70 and above over a 7-year period. And the key finding he realized was actually that almost half of them never went anywhere close to hospital. Now, this doesn't mean that you'll never go to hospital as an older person, but it reminds us now that if you make it to 65 years in our society, you have about 20 years of life expectancy ahead of you, and the majority of those years are going to be relatively good health. So that's the good news. And it reminds us that during the study period, that there are many people who are leading healthy and active lives in their community, and so we should really support to make sure that our communities can help people stay healthy and well. Another quarter of that pie represented people who used the hospital once over the 7-year period. And that might have been to get an elective hip replacement or elective knee replacement so they could continue staying active and independent. Now, the rest of the pie, that would be 100%, about 30 or so percent, were people who used the hospital 2 or more times. And in particular, he focused on 2 populations, one called the inconsistently high users and another called the consistently high users. And these were that 10% of the population, if you remember, that used 60% of the resources. And really what he said was that only a small proportion of older adults were consistently extensive users of hospital services. He showed this back in 1995 in the United States. That is still the same story today in Canada and the United States, and I'm sure in Taiwan as well. Now, the key thing was he focused on these 2 groups, and what's the difference? Well, consistently high users are people who might have a condition like congestive heart failure or chronic obstructive pulmonary disease, illnesses that we know that can land you in hospital on a very regular basis unless you have good primary care and other supports to make sure that you don't end up in the hospital frequently. Another group would be what we call the inconsistently high users. And these would be people who might have those conditions, but they might also have dementia, or they might have a mental health disorder. Because if you have dementia, you might forget to take your pills, for example, and this is why this significantly increases your risk of hospitalization by 2 or 3-fold compared to other older adults. And so that's kind of helps what distinguishes these 2 groups of high users in particular. But he also did one thing further. He actually said, well, what also defines these high users? Because you have a few clues now, but this is really important for the work that we're doing behind ACE because it reminds us what these people look like. And what we found is there's 3 particular things. One is these people have what we call polymorbidity. So when I told you about that older person who has congestive heart failure, okay, they probably have underlying coronary artery disease. They probably have high blood pressure. They probably have high cholesterol. They may have diabetes. I've named you 5 conditions right now, forget arthritis and other things, and you just need 4 of them to be a polymorbid patient taking multiple medications. So this represents a lot of the older people we often see in hospital. The number 2 issue is functional impairment, right? And this is why rehab becomes such an important piece. And our last speaker today will be talking about some of the work happening from that perspective. But we realize that when we talk about these individuals, they tend to be struggling with 1 or more of their ADLs, their basic activities of daily living, or their IADLs, those higher orders of daily living. So things like bathing, dressing, toileting, transferring, eating, these are the things that they're struggling with, 1 or more of these issues. The third aspect is something called social frailty, and we've heard about this a little bit over the last few days, where really we're talking about the fact that 25% of older Canadians tell us they don't have a family member or friend close at hand who could help them with a task like getting a prescription filled. So people who are leading quite isolated lives, and isolation can lead to loneliness, depression, and other issues, but it also means that they might not be able to get the supports they need to stay independent in the community. So you think about these 3 issues, and I like to say they're kind of the 3 pointy ends of a triangle, like the Bermuda Triangle. And if you're not identifying these issues and recognizing them in high-risk older patients, then you might miss an opportunity to support them as well. So if you look at this, and then you start thinking about the challenges that we call the hazards of hospitalization, you'll see, how this all works. So you take a look at this idea of having a functional older person. So the picture you saw a few minutes ago was of a patient of mine taken on his 100th birthday. He was an individual called Mr. W, who happened to be living independently on his own in the community till about 99. And that's when his CHF, his COPD, his arthritis, everything started actually making it harder for him to get to the pharmacy and get mobile. He became homebound in his 99th year of life, and that meant that he had 7 hospitalizations in 2010. I met him on his 7th hospitalizations 2 weeks into my practice as a geriatrician. Now think about this gentleman, because he was quite functional at home when he was well. He needed a walker, and he had a home care worker who came every morning to dress him and to get him bathed, but then otherwise he could get around his own apartment, okay? But whenever he'd get ill, when he'd get a pneumonia or get a urinary tract infection, he would start having trouble doing his transfers, basically the task of getting up and off a chair or even getting up and off the toilet seat. And so in this particular time I met him, he had a fall earlier that day, or he had a fall earlier that visit that occurred when he was trying to transfer from the toilet back to an upright position. So again, we know that 50% of older adults suffer a functional impairment in the 2 weeks prior to actually arriving at the emergency department, but how often are we actually inquiring to see what they were able to do before versus what they can do now? And then you bring a person into a hospital that's not very friendly, and these are the reasons why it's not very friendly. One is we serve our meals at very particular times. Today, if you did not have your lunch at 12 o'clock, you were not going to get fed, right? It wasn't there for you earlier at 11:30 if you were hungry, and if you came at 1 o'clock, they probably ran out of food, right? And so that's the idea that we have very set meal times. We don't ask Mr. W. If you asked him, you would know that he always liked to sleep in because he was 99. He was allowed to. And he would sleep in till about 11 o'clock, and that's when he'd have his breakfast, right? But again, so we serve meals at various times. And at my hospital, Mount Sinai Hospital, and our others, we actually have it written that we can wake our patients up as early as 4 a.m. in the morning because we have to have all the blood work done so that by 8 a.m. when the doctors start their rounds, the blood work is ready. So how many of you were up at 4 a.m. and how many of you would have liked to have your blood taken? And now imagine if you're an older person with dementia, you know, how would you have liked it? What would you have experienced if you were in that case? So also hospitals tend to be very depersonalizing areas. We tend to strip people out of their clothes. We put them in hospital gowns, right? It's hard to pronounce their names. Toronto's a very multicultural city, so it's very hard to pronounce names from different cultures. So we might actually just, you know, use nicknames to, call of our patients. And this can be a very depersonalizing experience. Older adults tend to spend a lot of their time in hospitals not on their feet, but laying down. We call this an epidemic of immobility. And the challenge is that every single day you're in bed, you lose 50% or you lose 5% of your physical functioning. So every day you're losing increasing functional strength, and that creates problems. And then there's other risks, and I won't go into too much detail, but the risks of malnutrition and dehydration, increased risks of things like delirium and other aspects. And then the idea is that when you're in hospital, if you already are polymorbid and probably have polypharmacy, you're getting additional medications and procedures that can cause additional complications. And so Bob Palmer, a real leader in acute care geriatrics, created this diagram to really say this is a recipe for creating a dysfunctional older person, because all of this together can promote more physical impairment and deconditioning and more depressed moods, delirium, negative expectations. And so Ken Kavinsky, who did a lot of work on this area of functional decline in hospitals, said that 1 in 3 people leaving a hospital has left the hospital worse than their baseline functioning, okay? And 50% of those folks will fail to ever recover the function they lost. So then if you look at, the daily newspapers, maybe here in Taiwan, but these are our newspapers in Canada, and they say, look, that our hospitals are unprepared to meet the needs of an aging population, and this is a real challenge. And so when you actually start looking at the spending we have, this is our Ministry of Health and Long-Term Care spending in Ontario back in 2010. So Ontario, Canada, is 1/3 of Canada's population. It's the largest province. And this actually shows spending on healthcare by age. So you have age in the x-axis, and the y-axis, the vertical axis, you have spending in billions of dollars. And you can see it's understandable that we spend more money towards the later years of life. That's what an aging population costs. But this is actually what we predict our spending will be in 2030. And really, the difference between the spending in 2010, which is about $50 billion, to 2030 is about $24 billion more. That's predominantly to meet the needs of our aging population if we do nothing differently, okay? So our dilemma is that the way in which our cities, our communities, and our healthcare systems are currently designed, resourced, and organized often disadvantages older adults with chronic health issues, right? And increasingly, our care needs and preferences and values are evolving as a society with increasing numbers of us wanting to age in our own homes, stay where we're living and age there. But the challenge is we have a whole healthcare system that doesn't really work well to meet the needs of older adults to stay independent in their communities. So this is why, again, we started our journey by saying we need to deliver a more elder-friendly approach. So Mr. W, who I told you about, if you remember the diagram of what happens to people in hospital, when he actually had his 7th hospitalization, this is actually what happened. He developed a pneumonia. he actually was supported by a home visiting doctor who gave him some medication. And that day that he actually fell, he had a son who didn't live in the city, but was actually coming to Asia, maybe Taiwan, for business. And so didn't like the idea that his father had fallen at home, while he was on pneumonia treatment, was probably getting better. So he called the ambulance to have his father go safely to hospital on a Friday night. Now, the weekends, as you hear, are not the best time to go to a hospital in Canada because we have our staff usually take their breaks on the weekend, so we don't have as many staff in hospital. So we came to a very busy, noisy emergency department at our hospital, and that's where he actually developed delirium, and other things started happening. He got catheterized, he actually had an IV put in, and this gentleman, who was cognitively intact, earlier that morning became delirious in our emergency department, and he went from being able to walk around his apartment with a walker to by Monday morning, when he was recovering from his delirium, he was what we call the two-person assist. He's a person who needed two people to walk him over to the bathroom. So that's how quickly we almost broke a 99-year-old man. Everyone was nice to him. Everyone was trying to care for him, but the way we were caring was causing problems. And so Mr. W's hospitalization was one of those ones where we realized we needed to really redo what we did, because when I met him on Monday morning, as the geriatrician called to see him, I realized that this man who was no longer delirious was probably able to get back home, but we now need to spend 2 weeks rehabilitating him. So we took out the catheter, we took out the IV, we brought in therapy, we refocused his care, and he was able to go back home. But the key was we had to really, he reminded us that we were not practicing in a truly elder-friendly way. So our nurses, our social workers, our therapists, we use Mr. W's example as a way for us all to get together and say, what would an elder-friendly approach really look like? And this is where we borrowed the name ACE, which was used for acute care for elders units, and we said, we don't need just a unit, which we built, but we also need to actually build a whole strategy that thinks about the way we care for people, not just in the hospital, but even before they come to the hospital as well. And that was the underpinnings of our strategy. We came up with 4 principles that we all agreed upon. We said our strategy wants to redesign or establish new sustainable interprofessional. So it's not just about the doctors, it's not just about the nurses, it's everybody. We want to create these interprofessional based approaches that enhance upon and improve upon current service delivery models. We wanted to make sure that this requires a shift in our thinking that underpins the administration and culture of most traditional care organizations. Remember, back at this time in 2010 in Canada, there was only one hospital, that was our hospital, that actually decided that year to say geriatrics is a core priority. We didn't have any other acute care hospital in Canada that said geriatrics is a priority. So that was changing the culture of our CEO, of our doctors, to say we are not only nice to people, but we are fundamentally going to prioritize the care of older people. Number 3, we said we want to make sure that we're not adverse to identifying risk factors and needs and intervening early to maintain independence. You heard yesterday Dr. Morley talking about, the importance of screening and using tools that are quick and easy to identify things that we can actually identify early. And so we want to make sure that we identify who are the frail older adults like Mr. W versus the very healthy and well people who can usually benefit from our usual way of caring. And then we can intervene early. And number 4, we want to make sure that we were looking at our data, because if you don't measure anything, then you can't monitor any progress. So we want to make sure that we were collecting data on everything we did so we could monitor our outcomes and use this to support continuous quality improvement. So we still meet 10 years later every quarter, look at our data and see how we're performing, and have used this to really improve the way we're doing our care. So a colleague of mine from Canada created this idea of an elder-friendly hospital model and really built this on 4 principles. And this is really the idea of thinking about the culture, which is, again, something that's been worked upon, as I understand, in Taiwan. So saying that we value older people. We understand that older people come to our hospital. And so we want to welcome older people and be friendly to older people as well. So again, that's a really important segment. But then there were 3 other things that we want to really focus on as well. We want to make sure that our environments were designed for caring for older adults, environments that promote mobility and promote function and don't promote delirium and those sorts of things. We also want to make sure that we have the right policies and procedures in place. Do we have policies or ways of working that are ageist, that actually disadvantage older people, and how do we remove that from the work that we do? And then how do we think about the physical act, or not the physical, but the actual models of care? And I think Dr. Wang, when he visited us last year and came around our hospital, he said, you know what you've really focused on? Not just the hardware, but the software. How do we actually process the way all of us naturally work to actually do things differently? And so all of these dimensions work together to minimize functional decline, promote safety, and mitigate adverse and social medical outcomes. That's kind of the philosophy of a real elder-friendly hospital, and one that we aspire to create. And so really, we're even actually 10 years later now saying this is not really just an acute care for elders strategy, but maybe we should call it an advanced care for elders strategy, really keeping the ACE moniker, because we like that moniker, but really, thinking about how we do things differently. And that's partly because the most important area that we started working on right from day one was our partnerships with the community. So I don't have time to go into all of this in detail. I'll just highlight some things. But for example, we made sure we partnered with primary care providers to create a home-based primary care program. So Mr. W, who went home, by the way, after 2 weeks of hospitalization, lived in his own apartment for 4 more years and 11 months, till 104 and 11 years, stayed in his home, had his primary care and his specialty care come to the home. Therapy would come to the home, all of that would be, and he only had 3 more hospitalizations over the next 5 years in total, after having 7 in 2010 alone. We also partnered, for example, with our paramedics. So our paramedics now actually analyze their data, and they identify people who are coming through quite regularly, and then are actually proactively visiting them first so that they don't end up coming in hospital. And we have outreach programs as well in the community that focus on high-risk older adults and those in long-term care homes, nursing homes, so that they don't have to come into hospital. We have a number of things we do in our emergency department. One is we screen every older adult to identify, are they a high-risk versus a low-risk patient? We make sure that we have specialized nurses in the emergency department who are focused on working with those high-risk older adults with the goal of getting them home and not having them be admitted, or if they're admitted, towards facilitating their care. We now have a policy where you cannot work in our emergency department as a doctor, a nurse, or a social worker unless you do specialized geriatric training. And then we also make sure that for our high-risk patients in our specialized community programs, when they come into hospital, we have a special email notification that goes out to the entire care team, the geriatricians in the hospital, the community care providers, the primary care doctors, identifying that person to allow a virtual conversation to occur. In our inpatient setting, we've looked at all the best models of practice that are out there, and we've worked with the folks who develop models like volunteer programs like the HELP program. We've now implemented that across our hospitals and also in our emergency department and in our rehabilitation settings. We also have developed ACE units. We have our consultation services, and we're also using the data that we actually collect on a daily basis through the nurses' documentation to help us inform the way we're providing care and identifying better opportunities as well. And then in our ambulatory settings as well, we run all the traditional regular and specialized clinics, for example, but one thing that we've really been proud about is using telemedicine consultation to better support older adults as well. So a few examples here about some of the work we do. And again, people will get copies of these slides so that you can follow along and get a little bit more detail. But some of the programs that we've been working on are the first sites in Canada that have now been approved to launch a hospital-at-home program. This is stuff that's been worked on in the United States, but also in Australia and the UK. And this is the idea that we know there's a subset of older patients who would benefit from hospitalization, but don't need to physically be in a hospital. This is a model of care where we actually bring the acute care into their own homes. And this is a model that's actually been shown to be quite safe for these individuals who don't need expensive tests and specialist appointments, but just need to be more closely monitored as they would be in a hospital setting, but we can do that at home. And in these models, the costs are lower, the patients experience fewer complications, and they're less likely to be dead at 6 months, so good reasons. I mentioned to you about this concept of community paramedicine, and again, we're traditionally used to the idea of paramedics or EMS or EMT technicians who go to people's homes and bring them to hospital. Well, now we actually work in partnership with our ambulance service where we have 10 specialized paramedics who now work with frail older adults in the community proactively so that we can avoid them coming into hospital as well. And in our model, where we actually work with high-risk older adults who are frequently visiting for non-acute issues, what we now do is we actually have a paramedic who will knock on their door and visit them in a non-urgent situation so that they can get a mini geriatric assessment. And I train all the paramedics myself. And by actually working in this model in our pilot year that we did this with 4 full-time paramedics, by actually doing this intervention, they reduced their emergency calls by 49% and transports to our emergency departments by 67% as well. We actually really focus on integrated consultation because we know that in Toronto, just like everywhere else, we have a lot of homebound patients who also have mental health and medical issues as well. And so what we've really focused on is using telemedicine to actually launch an initiative where twice a month we offer a specialist clinic where there's a geriatric psychiatrist, a geriatric medicine specialist, myself, but also a social worker, pharmacists, etc. And what we do is we actually will do a group consultation for these individuals with a telemedicine nurse who's gathered the information and sets up a telemedicine consultation. So doing this is how we can bridge hospital-based specialists with care for folks in their own homes. And in these models, we actually come up with a consultation and then a plan. And this is kind of what it looks like. It's all of us around the table when we have the patient at home with our nurse, our telemedicine nurse, and often their family members involved. And we involve the primary care providers as well so that we can, again, have a group consultation where we can problem solve together and then figure out a plan that we can work together. And in our model so far, 95% of the family doctors in the community are really happy with the model, and so are the patients and their caregivers as well. In terms of other models, we have a specialized program where we're working with 35 local long-term care or nursing homes. And what we do is we actually have mobile registered nurses who are actually going out to these homes in their model. We did the study with 15 homes to begin with, and really we showed this is a model that really focuses on prevention, avoidance, but also when the patients need to come to hospital, how do they rapidly engage with the emergency department so that the emergency department knows what the focus needs are, and then follow up. And the nice part about the model is that it actually has resulted in a 30% decrease in non-urgent and less urgent transfers to the emergency department, and it's actually it's more cost effective than a traditional ED visit, and everybody seems to enjoy this model more. In our emergency department, this is our brand new emergency department we're building at Mount Sinai Hospital in downtown Toronto, and part of the issue is that our population in downtown Toronto is now the fastest growing metropolitan city in Europe and North America. We have 120,000 new people every year coming in, so the pressure on our hospitals is unprecedented. So the government's approved us to double our emergency room size. And working with our emergency department, they said, we have a new emergency department, we're going to build it to elder-friendly principles. So we met together and we said, well, what are some of the principles we should do? And we said, well, if we have more bathrooms, the current emergency department has 2, but if we have more bathrooms, we can mobilize patients and not catheterize them as much, for example. So the chief nurse showed me the new plans after we met and discussed and said, are these enough bathrooms? Those are the things that are highlighted in orange. And I said, my gosh, that's a lot of bathrooms. I said that in my mind, but I said, that's perfect. Because she said, if we can now mobilize everybody, there's no reason to use catheters if possible. So again, it shows about using a physical design to promote function in that way as well. This is the screening tool that we use, again, a way that helps to prompt the nurses to think about the care that their patients need, especially if they're frail and older. And because we're still using paper-based documentation, that's why we're using a paper-based tool. And this is an example of one of Mr. W's notifications when he arrived in the emergency department in 2013. We all got the email, we started chatting back and forth, and we're able to plan a care to better manage his care and his transitions. We have an ACE protocol so that anybody who's admitted and older and frail, we make sure that we identify, and this is done by the physicians admitting the patient. They say if this person's had a recent decline in functional abilities, a change in cognition or behavior, problems common to older adults, complex social issues, or that emergency department screen that the nurses did, if they have 3 or more of these factors, they are now cared for under an inpatient ACE protocol that automatically gets involved an occupational therapist, a physiotherapist, and a social worker because they're probably going to be needed in cases like this. And this is an example of our order sets. We've taken our order sets and we've geriatricized them. So we took off all the bad medications in the hospital, we banned them. You can't order them now, okay? And our nurses said, if the person can be mobilized normally, the expectation is up in chair for all our meals, right? Because that promotes early mobilization, amongst other things. And then this is an example of how we're using our data from the nursing documentation every day, that you can do a real-time data pull that actually allows you to start looking at your patients with a more common geriatric lens. And this is a tool called ACE Tracker that my colleague Michael Malone developed in Milwaukee, and then gave us the software to use at our hospital as well. So this all sounds very impressive and interesting, but for those of you who are starting your ACE journey, does this actually make a difference? Does this actually transform the care, or just means that we're all friendly? Well, we've been collecting our data relentlessly. And so here's the story. In Toronto now, because we're a busy hospital and right in the center of town with an incredible number of patients, we're actually serving 53% more patients on our inpatient services than we did before. But I use the caveat that we're actually the hospital now that in Toronto, if you come to a hospital and to the emergency department, you have a 33% chance as an older adult of being admitted. You come to our hospital, you have a 27% chance of being admitted. Why? Because we're much better connected with the community. So it's very hard to get admitted to our hospital. But nonetheless, because we're in a busy, growing, rapidly busy city, we've served 53% more older patients today than we did 5 years ago. At the same time, we cut our lengths of stay for older adults, 65 and older, by 26%. We've actually decreased our readmission rates in 30 days by 14%. We actually decreased our pressure ulcer incidence by 93%. We decreased falls in our hospital by 66%, and the use of urinary catheters by 50%. Our patient satisfaction rate is between 99 and 100% for our older patients, so they seem to think that we're doing a good job. And in 1 year alone, we actually saved our hospital $6.7 million. So our CEO loves me being here right now because he says, you're doing good work, and so you get a break. Okay. So we're actually now working with hospitals all over the place, again, to think about our strategy as a way to build on great models of care as well. And really what we were invited to do a number of years ago was the Canadian government and 2 of its federal agencies helped sponsor our ACE Collaborative. And this is a model where we've been helping to coach hospitals across Canada, including the hospitals in Iceland, about how to participate and actually implement more of those models around the circle of care. So finally, what are some of the lessons that we've learned? Right now, you want to always invest your time in the right forms of R&D. Most people say that's research and development. I say it's called rob and duplicate, right? The idea that there are many smart people like Dr. Morley, who you've heard about, other people who've done a lot of great work. So we basically went to the people who developed the ACE units, Seth Landefeld and Bob Palmer, and said, you've done the work, tell us how to not screw it up, right? And so implementing that and linking it together, a lot of the good work has been done. So Taiwan's opportunity now is just say, take what's been done, take all of our ideas and duplicate them and steal them, People at all levels need to be supported, though, through change initiatives, large and small, and we need to communicate early and often and repeat. So this is culture transformation, and this means that our nurses need to buy in, our doctors need to buy in, and why, and reinforce when things go well, and repeat the benefits of that. You need to make sure that the organizational supports are in place, and you want to be selective with your asks. So what do we need from the IT aspects? What are the resources we need? What are the things that we need to do differently? Because we did this without any new investments in our hospital, right? We didn't get a big grant from the government. We basically said, if we can do this better and we can reprioritize what we do, we could actually save ourselves money. We also want to engage as many internal and external people. You saw our work was about transforming what we did in the hospital, but building strong partnerships outside of the hospital, making sure that we were having frequent leadership development meetings, looking at our data on a regular basis. And we have this mantra at our hospital saying, don't let perfection be the enemy of the good, right? So again, we're not going to get it perfect, and we never really got it perfect in the first place. But again, that's the opportunity that we can always learn from our mistakes and do better the next time. And again, we always take the opportunity to demonstrate our benefits of our care. So this was Mr. W. This was a picture taken of him, again, on his 100th birthday. This is after 3 months after he got out of hospital. He basically said, I'm homebound, so I can't come to your clinic, so thank you, goodbye. And I said, well, no, I do home visits as well, so I'll come out and see you. So you could see why he wanted to get back to his home. This was a guy who loved his books, right? He loved to read. Those are all his books behind him. And this is a person who very much wants to stay in his own home. You can see him with his walker. He has a medical alert bracelet, all of those sorts of things. But this was one where he was in charge and calling the shots. So again, effective care integration for patients needs to be a patient and caregiver centered and really bring a variety of care interventions where the patients are. Models of care need to utilize and deploy staff human resources flexibly based on what is practical and useful. Effectively integrating the care models with effective and efficient communication can significantly improve patient and system outcomes. And smart policies and proper payment models can enable good care. So thank you very much.
Thank you, Dr. Sinha. So we'll have discussion later after all the three talks. And so I have to echo Dr. Sinha for one thing, that sometimes names are very difficult to pronounce. So like I'm not able to pronounce the name of the university of our next speaker. But I still pronounce your name. So let's welcome our second speaker, who is also from Canada. And she's Brittany Ellis. Let's welcome Dr. Ellis.
Thank you. Well, we're getting loaded. Saskatchewan is the university, the province where I'm coming from. It's an Indigenous name that comes from the Native Americans in Canada. So after the presentation, we can all practice Saskatchewan. It means the river running through is what it actually means in the language. I'm just going to have a quick play here. Perfect. Perfect. Thank you for the introduction, and thank you all for attending. It's been such a fantastic experience being here, listening to all our wonderful speakers, and for my first visit to Taiwan. So, as you said, my name's Brittany. I am an emergency physician. I also have a background in public health prior to doing that, and was lucky enough in my training in emergency medicine to complete a fellowship in geriatric emergency medicine. Am I a bit quiet? It's usually not a problem for me. 1 second here. There we go. Better? Perfect. So geriatric emergency medicine is a newer subspecialty training that many of you probably will not have heard of. I was the second person in Canada to do so, and one of only 7 programs currently around the world training geriatric emergency medicine. So I've been invited here today to speak with you after having had the opportunity to work with Dr. Sinha and also Dr. Milady in Toronto. And I've now recently returned back to my home province in Saskatchewan, where I'm working as both a physician as well as a provincial lead for geriatric emergency medicine and really geriatric and care of the elderly in general. So I'm going to start my talk by telling you a little bit about the emergency department and emergency medicine, because I anticipate that most of you are not emergency physicians. Most of you probably have been to an emergency department, but the emergency department that you see today is very different from maybe what the emergency department looked like 10, 20, or even 30 years ago. I'm then going to talk a little bit about emergency department use by older people before I focus in a little bit more on some of the things that we're doing in emergency departments in Canada and emergency departments that I work in that focus on creating them to be more geriatric or elder-friendly. So Canada's current population is around 37 million people. It's spread across 9 provinces, 3 territories, and about 90% of those people live within 1 hour of the US border. That's created a huge divide in both health care, social care, education, and in general, creating a lot of inequalities around people and their experience of healthcare. I should have said that Taiwan on that slide is actually misrepresented. It's smaller than it looks in relative landmass to Canada. That's just how big of a country we face. And with that comes a number of problems. Canada, as Dr. Sinha said, is also experiencing this global phenomenon of aging, much like Taiwan. I'm sorry, just give me 1 second here. I just need to fix something on the computer that's not quite right. Perfect. So why am I telling you this about Canada? Well, Canada is really no different. Canada has emergency departments. There's emergency departments here. We face a lot of challenges in Canada. You face a lot of challenges here. as I understand. But I don't think that the principles of what we're trying to do are much different. And so I'm hoping that some of the messages I'm able to communicate with you today, you can take and adapt and adjust to the emergency departments that you have here. This data was taken from the UN World Population Perspective in 2017 and demonstrates those predictive demographic changes. Taiwan and Asia is represented by the orange line. Although there are significantly less older people proportionally now, you guys face, as we heard earlier this morning, a much more rapid rise in the demographics. These changes that we face, they're not a silver tsunami, they're not an apocalypse. We all saw them coming. We can all plan for them. And that's what we're here to do today. So I took the opportunity to fix some of the headlines that we see in common media. Like in Taiwan, in Canada, this is an opportunity. And I really hope that we can begin to see this as such. We should be celebrating the changes that have led to our elder population. Public health initiatives, which we've heard about so far, which continue to be celebrated, such as maternal and child care, vaccinations, various other initiatives around dentistry, access to medications, sanitation. Again, putting on my public health hat, but these are all things that we continue to celebrate. So the emergency department was first developed in the current kind of model that we're all probably familiar with in the 1960s. At that time, it was staffed on a rotating basis by a number of various hospital physicians and was often led to a chaotic care environment that was sometimes referred to as having dismal patient outcomes. It wasn't long, though, until emergency physicians and emergency medicine became its own specialty with its own training. This focus on rapid medicine, sick patients, trauma, the things we like to think about when we all watch popular television, is not the reality of emergency departments today. Within just a few decades, we went from this rapid sequence seeing lots of unhealthy, acutely unhealthy and well patients, to seeing a lot of more older patients with a complex medical needs, and even younger patients with complex medical needs. So over time, it's shifted. We now see patients who have polypharmacy. We now see patients who have significant mental health problems, which we never maybe had seen in the past in the emergency department. Globalization has led to an array of public health and infectious diseases that we've never seen before. And of course, we now see a lot more older people. As I said, emergency medicine is now a specialty on its own. Emergency physicians are trained in acute medicine. We're going to talk about that a little bit later. We now work in a very collaborative emergency department. It's no longer just physicians and nurses. We're going to talk about how we now work with physiotherapists, occupational therapists, pharmacists, and so much more. And pre-hospital medicine really changed the way and what we do in the emergency department. Yet despite the rapid growth and the rapid changes we've seen in emergency medicine, it seems like the patients are beating us. They're always a few steps ahead. Quickly and nearly universally, the demand upon emergency departments has continued to outgrow the ability of us to serve patients, leading to a common phrase that we've all heard of, overcrowding. I'm going to spend a couple of seconds just talking a little bit about overcrowding because I do think it is important to why we're doing what we're doing and also to the role that emergency departments serve for older people. So overcrowding is generally thought of as a situation in which the ability to supply emergency services is outweighed by the demand upon them, resulting in what we would think is an unreasonable burden, an unreasonable amount of time to provide those services. It's important. It's important because it's associated with bad outcomes. It's associated with people having falls, with increased rates of delirium. It's associated with people dying. There's many bad things that happen with overcrowding. When the emergency department was first created and overcrowding became a thing, the focus was, of course, on the emergency department. What can we do different in the emergency department to help fix overcrowding? So the focus initially was on personnel, it was on the environment itself, and it was on the clinical care provided in that situation. We started talking about efficiency models like Lean, Sigma 6. We're talking about human factors assessment. We're talking about the utilization of artificial intelligence and how we can improve the emergency department itself. And I believe these are all important things. But I also think that we need to look outside of the emergency department. So then we started thinking about beyond the throughput or the people moving through the ED, what else is a problem? Well, output. And Dr. Sinha had touched upon this as well. Output in the emergency department, we talk about beds in the hospital, a significant problem. We're also talking about people going into their own care environments, whether that's returning home, but for many people in Canada, it's going to long-term care. And long-term care is a problem in many societies. I believe that you guys are working on it yourself. We've heard a lot about long-term care 2.0. Not having reliable, timely access to long-term care means a lot of patients are staying in hospital, in their beds, and those patients staying in hospital, in their beds, are not allowing patients to move up from the emergency department, meaning that we're having a lot of boarding in the ED. I think moving past the throughput and the output, this is where we need to focus now, and this is where a lot of my work has somehow taken me, despite the fact that I'm supposed to be focused on the emergency department. Because what we're realizing is about the fact that what comes into the emergency department is probably one of the biggest predictors of how we're going to be able to care for people and where they're going to be able to go in the long term. It's unfortunately not a rare occurrence that I start a consultation in the emergency department by apologizing to patients for their wait, followed by them rapidly apologizing back to me. And I know it's a very Canadian thing that we apologize for everything that we do, but they're apologizing for the fact that they're using the emergency department for something that even they don't think is an emergency. But they're there because they don't feel like they have an alternative. They're there because the emergency department for so many people represents the only access to care. They might be there because they think it represents the best service, the best outcomes. Sometimes this is the case, but for complex older people, more often than not, this is not the case. These sorts of problems have come to the attention of many, and unfortunately, I continue to hear things about avoiding ED avoidance, ED diversion, and I think these are really negative terms. I think we're pointing the finger at the wrong place. We're pointing it at the patients, saying they're using the ED wrongly, when really, they're just using the only service that they can. Instead of helping them to avoid the emergency department, why don't we spin that? Why don't we start helping them to use better services? Why don't we provide them with better services in the community that they can use to not come back to the emergency department? So beyond supplying good emergency department care, which I promise I will get to, I do think we need to focus on appropriate and accessible care that happens before the emergency department. And I think that anybody that works in an emergency department cannot focus on improving care for older people without looking outside the walls of the ED. So EDs are overcrowded, but what do the numbers look like? These numbers are from a paper I found quite recently from Taiwan. So older people over the age of 60 in Taiwan were quoted as representing 27% of ED visits, yet represent over 40% of admissions. In addition, old age was found to be an independent predictor for both increased lengths of stay and mortality in the emergency department here in Taiwan. In 2015, Ko and colleagues published a paper about ED use among the Taiwanese public. They randomly selected a million people from the NHI database, and they looked at ED use based on stratified by age. What they found was that although older people did not represent the strongest majority of patients using the emergency department, they did have a much higher chance of being both frequent and highly frequent emergency department users. And I think this is, again, synonymous with some of the things Dr. Sinha was talking about those dollars going towards a small proportion of patients. So as we said, older people do not come to the emergency department because they really like it there. It's not always where they want to be, but they come because it's the best place for them. But really, is it? Are we just fooling them all? Perhaps. Many older people come with sensory impairment, cognitive impairment, and they're very vulnerable to the chaotic environment of the emergency department. They present with multiple concerns, polymorbidity, polypharmacy. At times, older adults may not even be there for a service that the emergency department can classically provide or fix for them. What we're seeing is that a high number of very frequent and frequent emergency department users are there not because they have acute medical concerns or even medical concerns at all. They're there because they're having problems with their housing. They're there because they're having problems with their mobility. Maybe it's a personal crisis and they have an underlying mental health disorder. But these are all reasons that we're seeing people come back and forth to the emergency department time and time again. Yet our physiotherapists, our occupational therapists, our pharmacists, our social workers are all in the emergency department from 9 to 5, Monday to Friday. I don't know if it's the same here. I haven't had the opportunity to explore much, but it is a problem we face. If you're lucky enough to have these allied health services, they're not always present when you need them. Not only are older people in the emergency department more, not only are they being admitted more, not only are they there longer, but they're also at a significant risk of adverse outcomes. In the emergency department, they've been demonstrated to have more functional decline, more falls, more medication side effects, and more delirium. They also have increased rates of returning back to the emergency department, of hospitalization, and of mortality. And those figures on the bottom, I believe, are from a Taiwanese paper. So now I'm going to get to hopefully why you guys are here. And I'm going to talk a little bit about a geriatric-friendly emergency department and what that looks like, some of the things we're doing, some of the things I've been a part of. Each of these topics is a presentation on its own, or multiple presentations on its own. I'm only going to touch briefly upon many of them, but I'm very happy to discuss these in more detail after, either over email or Twitter. So I'm going to talk to you a little bit about the clinical acumen and clinical care in the emergency department and what we're doing. I'm going to look at equipment and design in the emergency department, a little bit more about the care team and the people that we need in the emergency department to make it more friendly for older people, a focus on communication and transitions of care, and then again, look at some of the fantastic work that's going on outside of the emergency department, which I really think will have the biggest impact on the emergency department. So emergency departments in many places, and I believe in Taiwan, are essentially the main provider of primary care for many older people. We need to get better at caring for them, and we need to get smarter about caring for them. I'll put my hands up. I'm not a geriatrician. I have a lot more experience in geriatrics than most emergency physicians do, but I'm still not a geriatrician. But do you know what the training I got really helped me with was speaking the language, was understanding the terms. And that is something that I think a lot of emergency physicians cannot do. Not a single country that I came across routinely has emergency medicine trainees do any rotation in geriatrics. Yet we're all here because we all recognize that older people are a core user group in the emergency department, that we're not looking after them as good as we could be. So that's, I think, one of the first things that we need to look at is how we can get geriatrics into routine emergency medicine training. The timing changes how long you're trained in emergency medicine across the world. In Canada, where I trained, it's a 5-year program. I believe it runs roughly, when I look at media, from 3 to 7 years, depending on where you go. 1 month is not a lot to ask for. In fact, 1 month is not enough, but it's a start. It's a start, and it'll allow us to get these concepts instilled and this language instilled so we can all be speaking and coming from a common point. But the education can't stop there. Continuing medical education for both staff physicians, nurses, and I would even add on to that, anybody in the emergency departments, porters, care aides, physiotherapists, pharmacists, everybody should be understanding the principles of geriatric care and the major geriatric medical problems. And then Dr. Sinha talked about some of the implementation of clinical pathways, and that's something that has been shown to be very effective for various things. He spoke specifically about catheter use. I've been involved in and continue to be involved in a number of clinical pathways focusing on delirium screening, but it doesn't stop there. Screening is not enough. Screening for frailty, screening for delirium is not enough. I'm talking about pathways. I'm talking about what you do when you recognize that, yeah, they do have delirium. Or you know what? Maybe it is agitation based on their underlying dementia, but what do we do once we recognize that? And that's what I think we really need to focus on as well. The design of the emergency department is very important. Dr. Sinha, and in fact myself, I'm very lucky to have just within the last month moved into a brand new emergency department in one of the hospitals I work in. Unfortunately, as we all know, planning of these things take 10 years. It was well before my time that it was designed. But there's small things we can do, and there's big things we can do to make emergency departments more geriatric friendly. Simple things like having clocks with dates in every room to assist in orientation, having windows wherever possible, and when windows aren't possible, having lights on during the day and off at night. Sounds easy, surprisingly difficult in a lot of places. Minimizing disturbances overnight for boarded patients in the emergency department, not tethering patients to their rooms. If a patient doesn't need to go to a monitored setting, why are we keeping them on 24/7 monitoring in the emergency department? Just because we have it? I don't think that's a good enough reason. It's also associated with people having decreased mobility and increased risk of falls while in the ED. So having protocols in place to assist in appropriate use of monitors, as well as urinary catheters, as well as IVs, is very important to older people and how they do in our emergency departments. Beyond this, having chairs and beds which go up and down to appropriate heights for older people, encouraging them to get up, as Dr. Sinha said, meals out of bed, ambulating to the bathroom. Just because somebody comes into the emergency department doesn't mean they stop walking and stop functioning. And we, the royal we do this though. We bring things to their bed, we encourage them to stay in bed. If family members are present, encourage them to stay, encourage them to assist. Having non-reflective flooring and appropriate signage to encourage safe mobilization. Having railings, having chairs, appropriate chairs in hallways so that patients who can't do a 100-foot hallway have somewhere to sit down to encourage them to mobilize. In addition to the ED, the design, we need to look about what actually goes into it. We talked about some of the tethering, some of the equipment that we use, but I do think it's really important that not only are we able to assist patients and assess them using mobility devices, because often we say, yeah, you're safe to go home with your new walker that we just tested you in the emergency department with, but off you go find a walker. They may not be able to get somewhere to get a walker. They may not be able to afford that walker. And now suddenly our safety plan to get them home is no longer safe. So I think we actually need to have supplies and resources in emergency departments for select patients that they can try, we can assess them with, and they can take home. Sorry. Looking beyond the equipment and the way we build emergency departments is the team. No longer are emergency departments team, as we've all alluded to, made up of doctors and nurses. For a lot of older people, we are but a very small piece of the puzzle. We now need to look at the role of social work, assisting us in doing evaluations, assisting us in organizing care that's appropriate for the patients, assisting us in finding alternative care pathways when maybe they don't need an acute admission, but maybe they do need rehabilitation. Maybe they have been suffering in their own home, but it's a long, gradual decline, which we talked about as being not the ideal, but it does happen. And social work can often help us with finding appropriate arrangements for those patients. We need physiotherapists who can assist in ambulating patients, providing appropriate equipment, who can provide exercise plans, who can help us to get some of those patients home with fragility fractures that don't require an operating room, but do require safety. We need occupational therapists who assist us in many of the things physio does, but in addition, they also assist us in cognitive assessments, capacity assessments, and again, home safety, home equipment. Pharmacists. Pharmacists are probably one of the most underrated, fantastic care providers in geriatrics and in the emergency department. I don't know any of my colleagues, that could even list 5 medications that are contraindicated in older people or on the Beers criteria. Yet I believe there's 120 on the Beers criteria that are associated with poor outcomes in older people. pharmacists to help us with our complex patients' medications review, and to assist us in ensuring that we're not having any medication side effects or reducing the risk of medication side effects are very important. Dr. Sinha spoke about geriatric specialists. In many places, that model looks different. Geriatric emergency medicine nursing or technologists, people who can assist us in doing a more comprehensive evaluation, of pulling in family members, of providing some of the history that sometimes is very difficult for busy emergency department teams to gather, and for linking all these other services that we have involved, for arranging follow-up care, for ensuring patients who we were able to send home are home safely and doing well. Volunteers are something that we're increasingly recognizing the potential of in Canada. I was fortunate enough to be involved. Many of you may have heard of something called the HELP program. It's a complex care program designed largely by Dr. Sharon Inouye in the United States, who's a geriatrician. And it uses a number of different factors to focus on reducing delirium while in hospital. Part of that was volunteers. And volunteers have been shown to have an a significant effect on things like improving patient loneliness, reducing social isolation, and even getting patients up and moving, assisting them in eating, assisting them in hydration. So we've, in Toronto, developed a program called Maximizing Aging Using Volunteer Engagement, or MOVE. There's an inpatient part and now an emergency department part. And over 6 months, we were able to interact with and assist over nearly 1,000 patients who attended the emergency department who were identified as being at risk. And we did things like that. We assisted them. Some of it was sensory impairment, so providing them with reading glasses or sleeping masks or earplugs or hearing amplifiers, water, food, warm blankets, all of the things that really help, as well as social visits, orientation. So it's been a very effective program. We're having very positive feedback, and we're looking at a more formal evaluation process. But we do think it works, and we do think that it's something worth spreading. Uh-oh. Was that because I ran over time? Okay, good. Looking briefly at communication and transitions of care. So in Canada, about 15% of people don't have a family physician. And for those who do, inaccessible family physicians are a big problem. People don't get sick 9 to 5, and if they do, they have to wait 2 weeks to get an appointment. I understand here the primary care model is very different to that in Canada, and in fact, many people don't even have a primary care provider at all. I really do think that they are, and they should continue to be, the backbone of services and care that we provide. They help to link services for patients who are complex, who have multiple parties involved. They coordinate services, and they have a very broad, overarching understanding of what's going on with their patients. In the emergency department, family physicians are very important for not only providing us with information, but also somewhere that we can provide them with information. So ensuring that we provide them with documented, clear, and written discharge instructions, not only to the family care provider, but also to the patient. And when patients come to us from long-term care in Saskatchewan and in Toronto, we're looking at and currently utilizing different frameworks for ensuring that the required information that is up to date, keywords, are sent with the patient to the emergency department. And lastly, just a look at some of the models which I think are the most innovative, and again will probably have the greatest impact in what we do in the emergency department in many ways, is looking outside the walls of the emergency department. Dr. Sinha spoke about community paramedicine and the role it's playing in Toronto. Where I'm from in Saskatchewan, to give you some perspective, it's greater than 30 times the size of the United Kingdom, and there are less than 1 million people that occupy the entire space. Having broad rural settings is a complex issue, and community paramedics who not only perform social visits to check on frail older people, but also perform assistance in managing chronic disease such as COPD and heart failure, are a huge part of the success and our ability to keep patients in their own home. And these projects are very diverse, and they're ranging from being called out for falls assist and not transferring to hospital, and these sorts of things. Looking at interprofessional community care projects, Dr. Sinha again spoke on this, but in Saskatchewan and where I am, we're currently developing a project looking at having a multidisciplinary team that's accessible in the community, that acts as a primary care team, but also follows our at-risk patients who are discharged from the emergency department for a brief time. Our goal right now is to look at how we can prevent them from returning unnecessarily to the emergency department when we really know that having a well-functioning primary care team is what they truly need. Geriatric short stay units are a concept that is very fertile, especially in the United Kingdom, having things like acute frailty units where older people who may require short admission but do not necessarily require what ends up being a 1 to 2 week admission are able to go directly from the emergency department, often to see a geriatrician, have a comprehensive geriatric assessment or even a more brief version of that, and to arrange appropriate care in their home, which may not be possible from the ED specifically. Rehabilitation units and centers are a huge part of being able to get people home or getting them to an appropriate care environment. In Toronto, they had a nice pathway where patients with non-operative pelvic fractures, non-operative proximal humerus fractures, Colles fractures, these things that often patients end up getting admitted to the hospital for just rehabilitation, when we know that rehabilitation is often not done well in hospitals. You might speak differently to that, but I think that getting them to rehabilitative centers directly from the emergency department would not only increase our flow through the emergency department, but would also increase patient outcomes. And looking at, again, home care and long-term care and how we can have rapid access to high-quality services that help us to get patients from the emergency department back home, back into a better environment. So, key messages from the talk that I hope I was able to share with you are that older people are a core user group in our emergency departments. To make emergency departments more geriatric friendly, we need to look in the emergency department, but we also need to look outside. We need to focus on accessible and appropriate care. And that there's a lot of really fantastic things going on and a lot of opportunity for change and a lot of opportunity for improvement. So thank you for listening, and I guess we'll take questions after.
Thank you. Thank you, Dr. Alice. And yeah, we'll save all the questions later. And for the third speaker, that a few years ago, at JAMA, they had published a review regarding to how to prevent the hospitalization-associated disability. That is a key issue for the age-friendly health services. So our next speaker, Ms. Jean Cooper, is going to share her expertise in organizing the network for rehabilitation. So let's welcome Ms. Cooper.
Hi, so good afternoon, and Dr. Chen, thank you for your welcome. And it certainly is a privilege to be here today with you all, and also to be taking part here with the Global Health Symposium. Spalding was also very honored in August to host the Vice Minister of Health and Welfare for Taiwan in Boston, and to share a little bit about our rehabilitation services. So what I'd like to do today with you is talk to you a little bit about rehabilitation from our perspective, from our model of care. So what I'd like to do is introduce Spalding Rehabilitation Network, talk about and consider post-acute care options for elders, and highlight a couple of the programs that Spalding is doing, our Live Long, Walk Strong program, and also Partners Healthcare at Home mobile observation units. So Spalding Rehabilitation is located in Boston along the eastern seaboard of the United States. And we are actually based, most of our services are based along the east coast of Massachusetts. And along here you can see blown up, you can see that we have in the middle Spalding Rehabilitation located in Boston. And then we have several satellite facilities that are located throughout Massachusetts, and those are primarily outpatient facilities. So at Spaulding, our mission focuses on improving the quality of life for our patients. We also work to prevent illness and injury. We work with weekend warriors, as well as those who have experienced a life-changing event. And we work with individuals across their lifespan. So our goal is to help our patients to find their strength. And there are 4 pillars that are integral to supporting our mission. That's clinical care, education, research, and advocacy. And our vision is bold, and it's focused on being the national leader in rehabilitation and increasingly focused on international collaboration. Spaulding is recognized as one of the top hospitals, rehabilitation hospitals in the country, and we are very pleased to have been ranking in the U.S. News and World Report since 1995. This year we're ranked number 3, and this is actually our 2nd year in a row for being within the top 3 within the United States for rehabilitation services. And we really think that the success for our programs really focuses on the quality of our programs, research, training, and community involvement. So Spaulding Rehabilitation is part of a larger healthcare network, and that is called Partners Healthcare. And Partners was founded in 1994 by Brigham and Women's Hospital and Massachusetts General Hospital. And these are 2 academic medical center anchors for the system. So Spaulding, which is here in the middle, Spaulding Rehabilitation Network and Partners Healthcare at Home serve not only our 2 academic medical centers, Brigham and Women's and Massachusetts General, but also other community hospitals and specialty hospitals which comprise the network. And here it shows you a little bit more in depth in terms of what our network looks like. And so here, Spaulding Rehabilitation Network, and I'll go through and talk a little bit more about what some of these different facilities are. But when you take Spaulding Rehabilitation Network and our series of inpatient and outpatient facilities, and then you add in Partners Healthcare at Home, which is home care and advanced clinical programs, these 2 combine to create what we call Partners Continuing Care. And really our goal here is to provide an integrated post-acute care system and service delivery. So Spaulding is affiliated with Harvard Medical School, and we are the official teaching hospital for Harvard for the Department of Physical Medicine and Rehabilitation. Our residency program is ranked number 1 in the country in 2018 for overall reputation. Additionally, we support the development of nurses, therapists, and other allied health professionals through clinical placements and other learning opportunities. Additionally, research and innovation are integral to our mission, and our research is robust. We have over 100 different studies underway, and annually about 200 publications. And we have, are home to about 70 Harvard Medical School researchers. Spaulding is also home to nationally recognized model systems of research and care for traumatic brain injury, spinal cord injury, and burn injury. So let me give you a brief overview of Spaulding's post-acute care network. We have 5 key areas of service that we provide. Inpatient rehabilitation, and this is for intensive interdisciplinary rehabilitation following illness, medical treatment, or accident. Facilities are, we have 2 facilities, and those are Spaulding Boston and Cape Cod. And typically we will treat patients here with spinal cord injury, stroke, and brain injury, among others. And Spaulding Rehabilitation Boston has a 12-bed pediatric unit. And our average length of stay is 2 to 3 weeks. Long-term acute care. Our hospital is located in Cambridge, Massachusetts, and provides complex acute care services. And so it's common that we would see patients that are recovering from transplant, post-transplant, and ventilator patients. So patients that require a lot of intensive care and support from a clinical standpoint, but also requiring some rehabilitation services. Our patients here have intense medical and nursing needs, and the average length of stay is 1 month. Skilled nursing facility, we provide services typically for elderly and others, and this is where we will commonly provide support for post-joint replacement patients and wound care. Our patients may have long-term skilled nursing needs or short-term rehabilitation care needs. And average length of stay is 2 weeks to 3 months. So with all of those facilities that I've mentioned thus far, we have a total of 5,500 inpatient beds, which is, in comparison to hospitals in Asia, probably even combined a low number of beds. Or a low number of inpatients that we serve, actually through 500 beds. We also have outpatient or ambulatory services, and this is one of the areas that we see our greatest growth. We provide, within these settings, we provide orthopedic care, sports injury support, and also amputee recovery services, among others. And in our network, we have seen about 468,000 outpatient visits throughout the network each year, and about 50,000 new evaluations annually. Home care is another area where we're seeing an increase in growth and interest. Obviously, people want to be at home, surrounded by loved ones, in comfort, areas of comfort, especially as people are aging and older. It's certainly a preference where possible. We have, our home care staff includes 320 visiting nurses. We have 265 visiting therapists, and they make over 500,000 home visits each year, clock 3.2 million miles, which I think is about 5.1 million kilometers annually in the services that they provide. And also serve about 3,000 patients remote through telemonitoring. And we also have different types of technologies that support care at home, and we'll talk a little bit about more of those a little bit later on. So these numbers that are listed up here reflect services that are provided at Spaulding Rehabilitation Hospital, or our hospital in Boston. But throughout our network, we have, and across our facilities, 110 physicians, physiatrists, residents, clinical fellows, neuropsychologists, 555 registered nurses, 440 physical therapists, 235 occupational therapists, and 135 speech-language pathologists. For our inpatient programs, let's see, listed up here: brain injury, spinal cord injury, and what we call comprehensive rehabilitation, which includes orthotrauma, burns, cardiac, as well as and we also amputee recovery programs. Stroke rehabilitation and neurorehabilitation are key and ones that we see and treat many patients for. And then we also have a small dedicated pediatric rehabilitation program as well. And CARF, as you'll see noted on several of these areas, CARF is Commission on Accreditation of Rehabilitation Facilities. Is a certain type of accreditation that rehabilitation facilities can achieve, and it's similar to concept of Joint Commission or Joint Commission International. And in addition to the patient and family, our philosophy of care basically puts patients at the center of everything that we do. And in addition to patient and families, the multidisciplinary rehabilitation team may include a number of different types of providers. Certainly physiatrists, rehabilitation nurses, clinical social workers, physical therapists, occupational speech language pathologists, music therapists, recreation therapists, respiratory therapists, nutritionists, among others. So it really takes, we cast a wide net, and it certainly requires many people to provide the expert care that we look to provide. Our outpatient offerings, as listed here, are certainly very robust and are geared to meeting people for various types of injuries and recovery, as well as along the lifespan, as well as our community specialty programs. And many of our programs that we do are in collaboration with community-based agencies, so local gyms, schools, senior centers, really trying to get the care at in the community where patients live and reside. So when we think about geriatric rehabilitation, we actually have a specialized program at Spalding that focuses on the needs of our geriatric populations. And within the United States, the fastest growing segment of our U.S. population is over 65. And according to the U.S. Census Bureau, more than 70 million people will be over the age of 65 by 2030, and 20% of the U.S. population will be 65 or older by 2050. So certainly not at the pace perhaps that we heard earlier about Canada or that we're aware of from Taiwan, but certainly a significant need that we all share. So our clinicians use a coordinated approach to treat elderly patients, considering multiple factors that may impact each patient's medical condition, their support system, potential for recovery, and independent living. And then we also work to help transition into community-based exercise programs or adaptive sports programs as well. And so, as I talked earlier about the different types of levels of care that we can provide within Spalding Rehabilitation Network, we certainly have identified and developed programs for meeting particularly geriatric patient needs across that span. So one particular program that we've adopted and incorporated is called the Live Long, Walk Strong program. And the reason for this is that, falls are the leading cause of fatal and non-fatal injuries for older Americans. And 1/4 of Americans aged 65 or older fall each year. And falls result in more than 3 million injuries in emergency departments annually, and including over 850,000 hospitalizations and more than 29,000 deaths. Just a couple of the statistics there. So really what we were looking to do was to develop and implement a program that was focusing on conditioning and prevention. And so the Live Long, Walk Strong program is part of Spalding's Research Center for Lifelong Health and Fitness, and it's at one of our locations at Cambridge. And it responds to the needs that initially were identified by primary care physicians that provide services within that immediate area, and who were helping to support patients with multiple comorbidities. They were having and seeing multiple hospitalizations and injuries. And so what this program does is it's customized to the individual and is based on an evidence-based practice, but provides for sort of like a geriatric, we call geriatric boot camp. In the United States, boot camp, gym and physical fitness is very popular. I'm not sure how that translates here in Taiwan. But the idea is to build conditioning, build the strength of the individuals, help them to feel more comfortable and confident in their ambulation, and hopefully prevent falls and injuries and prevent the injuries before they happen. So the Live Long, Walk Strong program may include several components: physiatry service, one-on-one rehabilitation services, functional assessments, individualized exercise programs, functional task modification, home safety recommendations, coordination of care between healthcare providers, behavioral change strategies for promoting lifelong exercise, healthy aging habits, and recommendations for community-based exercise transition. Another program that we provide is, supports population health management, and again, with the goal of reducing hospitalizations. And that's something called the Partners Mobile Observation Unit Program. And what this does is it looks for opportunities where patients who may present in the emergency room with different types of diagnoses perhaps could be managed at home with appropriate clinicians and clinical care coming to the home to support the patients. And so this is a home-based urgent care for patients experiencing at-risk medical events believed to be treatable with enhanced home care. And we have a nurse practitioner that we deploy to a person's homes to help to initiate the plan of care and assess the situation to assess safety for the patient to remain at home. Certainly our goal is reducing the hospitalizations and uses of emergency care, and to make sure that we are engaging and mobilizing diagnostic services, IV treatment options for in-home support. For our home health care and for the mobile health unit program that I just mentioned, we also have different types of technology that can support patients hopefully remaining at home when and as clinically appropriate. So one of the types of technology that we provide is Lifeline, which is a fast access to emergency if patients can't get to the phone. And it's a help button. It has a help button that patients can push with auto alert options so that, for example, if a patient were to fall, they could, the fall or the change could be detected, as well as locating technologies for where they are when they fall. Home key box, so that if emergency personnel need to gain access to a person's home, they are able to do so without having to break a door or find other alternative ways for entering in. And also, and then telemonitoring, we have the telemonitoring program, which is a way to monitor vital signs. We have nurses that monitor vital signs, symptoms, including blood pressure, heart rate, glucose, oxygen, weight, health status. So that is something that patients can opt to do. And then we also have something called the Connected Cardiac Care, which is a home telemonitoring program for persons that are diagnosed with heart failure. And this is a 4-month program that allows for monitoring of health daily and then allowing management of heart failure from the home as opposed to being inpatient for those services. And then we also have technology that supports medication dispensing, and it helps them to manage medications without hopefully increasing patient safety, minimizing worry and confusion. And an alarm will actually send off when a patient needs to take medication. So it's a great, helpful reminder for patients. And let me see if this, link give you an idea of some of our telemonitoring at home. I think it's
My name is Karen Federico. I'm a registered nurse working for Partners at Home. Telemonitoring.
Apologies.
My name is Karen Federico. I'm a registered nurse working for Partners at Home. Telemonitoring helps the patient actually stay out of the hospital. Every morning, Mr. Bose, who has hypertension, takes his vital signs through the monitor, presses the send button, where I will receive it on my end so that I can check to see what they are for that day. Many patients we've had will talk to us because they feel that one-on-one. We give them the training that they require to take care of themselves at home.
No worries. Here we go. Okay. Thank you. Thanks. So it gives you just a little bit of a flavor, but I think that the telemonitoring services that we provide are very similar to ones that are available here in Taiwan based on the plenary session I heard earlier today, as well as elsewhere around the globe. So in addition to the services that we provide that I've talked about, we are certainly very much committed to local, national advocacy for the elderly, but also for all patients that we serve, including for patients with disabilities. And this was actually several of our leadership that were participating in a celebration of recognizing 25 years of the Americans with Disabilities Act. And some of the things that we are committed to doing are internalizing, basically what we'd say is putting our money where our mouth is. Looking for opportunities that we internally within Spalding Rehabilitation Network can also make sure that we are promoting and advocating for our patients. And so we embrace the concepts of universal design and accessibility at our organizations. We promote workforce development for people with disabilities. We enhance the lives of the communities we serve through legislative advocacy. And several of our staff sit on different types of community-based boards within the communities that we serve. So one of the things that we also look to do is to share, as part of our mission and strategy, to share our experiences, our lessons learned around the globe. And so to do that, we have a program called Spalding International. And we provide different types of services for communities and for organizations that are looking to develop and advance their rehabilitation services. And so these are just some examples of some of those services that we provide. And thank you very much for your time.
Thank you, Ms. Cooper. And the staff is preparing the seats on the stage for our discussion. So before that, I would like to clarify a few things, a few facts, so that we think that it will facilitate our further question and answers. So first thing is Taiwan has many nursing homes, but it's more like the long-term care nursing home. So even though sometimes nursing homes call themselves as a skilled nursing facility, but it's not that intensive. So physicians or medical treatments or therapists are not that, the availability is not that good as an American skilled nursing facility. So it's more like a long-term care nursing home in Taiwan. So that's why post-acute services in Taiwan rarely go to nursing home. It's in the community hospital. And the second thing is the health care service, the financing system in Taiwan, which is very different from Canada or the United Kingdom, the public service system. That we have a universal coverage for the health insurance. Basically, it's public. But each individual hospital claim the services to the national health insurance. So the CEO of the hospital is trying to make bigger revenues, which means more healthcare expenditure, so that the hospital can make money. Unlike the system in Canada or the United Kingdom, the CEO is trying to reduce the expenditure so that can make the biggest profit, because it's more like a capitation system in that system. But in Taiwan, it's more like fee for service. So some good things, we know that's good, but it's hard to be implemented sometimes. Okay.
I just wanted to comment on just as we're getting set up, but Prof. Chen was just talking about kind of different financing systems. And so sometimes people say, well, you know, does some of what we're talking about, does it, you know, how does that actually impact the care that we're doing? And does that work against, you know, ACE principles or what we've all been talking about or not? And it's interesting because, for example, when I was working at Johns Hopkins, you know, when we talk about our gem nursing model and how it actually helps prevent, you know, admissions to the hospital, you know, my mentor said, well, that's crazy that you promote that in Canada. Like it's a good model for Canada because every time a person's admitted to the hospital, you know, it costs the hospital money to treat them. And so the incentive is to avoid admission, where in the United States, you actually want to drive up as many people to come in because, and in fact, some hospitals have admission rates of 66 or 67%. Like if you're old, you come in because we then get paid as soon as you get admitted. So there are these perverse incentives. The interesting thing is that as we're seeing around the world now, that a lot of the ACE principles work in all systems. For example, even, you know, I joke with my CEO that if I was actually at a US hospital, we wouldn't be saving 6.7 million, for example, we'd be making many more million, because when I'm taking care of 53% more patients in our acute care environment, but actually with a 27% lower length of stay, if we were on a US DRG payment system, I would have millions and millions of dollars of profit to play with. And so this is where we're trying to talk about, even in Taiwan or in the United States or Canada, these principles that deliver better care, less complications, actually there is profit and support to be had in that model. And even bringing geriatrics, we have 1,000 rehabilitation beds across our network of hospitals where we've implemented our geriatric models. By bringing geriatric principles, like Dr. Ellis was saying, we've significantly reduced our negative outcomes, improved our patient stay. So our rehab hospitals love our models because we've geriatricized them. So I think the key is, there are ways that you can look at these models as ways that no matter how things are financed, good geriatric care saves money, delivers profit if that's the goal. And so it's not a negative, it's actually just understanding how financing works within a system and therefore how to actually show the ACE's benefits that way.
I'm a practicing geriatrician. I'm totally on your side. Just sharing the common, the background. There's some may ask questions under that background. So that's it. So, is there any question or comments from the audience?
Hi, I'm Ling Hugh Chen, and in occupational therapy, and I actually work in Sporting Rehab Hospital from 1995 to 1997. So I'm really glad to hear, you know, it's changed a lot, it seems like. But anyway, and I have a question. It was Sporting post-rehab acute. Well, Sporting is a post-acute rehab hospital, right? So I assume that it accepts patients who can tolerate at least 3 hours of rehab. And I was wondering, you know, and so you have like brain units, SCI units, you know, all these patients, I would imagine they tend to be younger. And I was wondering, for people who are like older, like 70s, 80s, 90s, you know, they often have more complex medical situations, you know, they can change day to day. And when they are no longer be able to be in an acute hospital, and they are transferred to a post-acute hospital, and how to, well, I think the question I want to ask is, supporting geriatricizing post-acute rehab. I think that's an issue that I like to, if we have more discussion. Thank you.
Sure, thank you, and hopefully we can talk afterwards, because I'd love to hear more of your journey since you left Spalding. But thank you for the question. So as you mentioned, in the United States, for inpatient rehabilitation stay, a patient needs to meet certain requirements, and one of those requirements is 3 hours of intense rehabilitation every day. And that could be a combination of physical therapy, occupational therapy, speech therapy, but there needs to be 3 hours a day. We do actually see patients at our inpatient facilities, both in Boston and in Cape Cod, who are older. In particular, we have a stroke rehabilitation program within neurorehabilitation. And so, especially within that stroke population, it's not uncommon to see folks who are 65 or older. What we look to do on a couple fronts in terms of the care that we provide, and that would be not only in the inpatient facility, but perhaps if a patient was not able to tolerate, let's say, 3 hours of rehabilitation, had multi-comorbidities, and perhaps needed additional time to recover, then they might actually go to the skilled nursing facility for some time, in which case they can continue to recover. They'll receive some rehabilitation. Depending on how that recovery and that pathway continues, they may stay there for a period of time, could possibly transfer to our inpatient rehabilitation, or be in a position to actually receive perhaps continued care and services on an outpatient level, and return to home. So there's a lot of different ways that a patient may experience that journey. But I'd say through all of those different approaches, we certainly look for ways that we can meet the needs of older populations within those various settings. And so looking to some of the points that Dr. Ellis and Dr. Sinha made earlier in their presentations, looking for opportunities to minimize some of the noise, the lights, or using lights appropriately to try to minimize sundowning or dementia within our patients, making sure that information that we provide, perhaps for people that might be have visual impairments, being able to read information in print, looking for opportunities to customize the care that's provided, understanding what the patient's needs are and how best to respond to them. So I think to Dr. Sinha's point about meals being only served at certain times and such, trying to really understand what the patient's needs are so that we can really customize what their care, how best to deliver that care.
And just to build on Jean's work, the things that we've also tried to do further is we've kind of our ACE strategy spans 7 hospitals. So we have 3 acute hospitals, a cancer center, and then we have 2 different rehab networks, one called Bridgepoint, and then one called Toronto Rehab, for example. So that's 1,000 rehab and skilled nursing facility beds. But what we tried to do is try and think about other things we can do. Dr. Ellis mentioned, for example, that patients coming into the emergency department who really just need acute rehab, instead of admitting them to the acute care environment and all those problems there, we actually clear them in the emerge. They're seen by the therapist, we assess them for rehab, and then we admit them directly to the rehab bed, avoiding the acute side. But we also have now, by having geriatricians based in our rehab environments, we're now doing a direct admissions from the community. So with our community-based teams who are seeing patients who really just don't need to come into an acute care environment, but need that expertise that we would get in a rehab setting, we're doing direct admissions from the community. And then by having a geriatrician or geriatric trained professionals involved in the care, the other thing, the reason that our rehab hospitals got us involved was because they said, our patients, we don't want to take sick older patients in need of rehab. We want to take healthy patients, except for the fact is most of the people needing rehab now are older patients. In fact, 85% of our patients we serve in our rehab hospitals now are older adults. and they have many comorbidities, much more complexity. And often if they came after a hospitalization for heart failure or other things, they'd have medical complexity, and then we'd call the ambulance and send them back to the acute hospital. By having internists and geriatricians involved in the care, we've actually been able to decrease what we call service interruptions and actually get them recovered more quickly, because often we think about what's slowing down the rehabilitation of that older person. It's poorly treated pain, for example. It may be issues with cognition and other things that we still need to attend to after, say, their hip fracture surgery or other things. So it's just trying to think, how do we think about our rehab environments, like Spalding and others, as ones where we have to think about those nuances even more so with time so that we can deliver better care. So just some of the other ways that we're evolving that care further.
As I didn't see the others, so I tried to take this opportunity. I'm Dr. Suti Cho, the chair of the International Task Force on Age-Friendly Healthcare. I wonder if you would mind that if I use this opportunity to link today's session with something we are going to do on December 20. Yeah, I think it's wonderful to have such discussions and exchanges of the best practices in delivering safer and better care for older patients. Okay, so in the age-friendly healthcare design, we have a framework, and we emphasize on organizational management with policies to support such best practices. And we emphasize on age-friendly environments, including physical environments and social environments. And we emphasize on age-friendly care processes, including the universal risk assessment, universal risk intervention, and evaluation of the effectiveness. Okay, so I think such an opportunity to get together is so important, especially it's very encouraging to our frontline people. And I think actually, our experts were invited here not only because they are doing a good job, but also because they evaluated the result, and they published their result in the scientific journal. So in December 20, in Taiwan, we are also going to have a local scientific conference on age-friendly healthcare. So I'm using this opportunity to do a social marketing on this a very important event. As you have heard from Director General Wang, actually we have started this initiative for several years, and Dr. Chen is helping a lot. And we have more than 500 certified healthcare institutions working on this. So may I translate this into local language to our colleagues here? Thank you so much. 12月20号，就是说我刚刚是在讲说，其实我们各位呢也做了非常多的努力哈，在高龄友善健康照护。但是非常重要是我们不但要做，而且我们要交流。别人怎么做，我们怎么做，而且呢，更好的话是把它做一个分析，写成论文。所以12月20号在振兴医院，那我们有一个高龄友善健康照护学术研讨会。那我非常鼓励大家把你们所做的那做一个整理，好分析，然后投稿。然后呢，我们会有比赛，那个最佳论文我会给你一点点的那个奖金。And now I'm going to say the web link for their 你们可以報名啊哈，那個 http 然後2橫斜線 pse.is 然後斜線 LDUKT. Should I repeat that again? Sure. I should be also client friendly. Yeah. http 冒號2個斜線 pse.is 然後斜線 LDUKT. And also furthermore, next year in South Korea, the International Conference on Health Promoting Hospitals and Health Services will have the theme on healthy aging and innovation. So very much in line with this year's topic. So it's wonderful to have you here, and I also hope you also attend next year's meeting in Korea. And 各位大家今年把它写一写，然后年底跟明年年初记得去投稿，就到国际去发表，这样子好吗？我们就会请老师来选出最好的 abstract， 然后给你就是找这些选出前几名，然后来报告，然后就告诉大家说你们常见的缺点在哪里，然后帮助大家 to complete the one extra mile to get published to share the evidence. I think that's very important, and you are contributing to the world's progress in this field. Thank you.
Yeah, fantastic. I love that you just did that. If I could make one suggestion just to ensure that it's included in any of the conferences that you're currently designing, is to have some forum for our frontline workers, myself included, on how to collect data at a local level and what that actually looks like. Because traditionally it's, especially in the emergency department, but I think in many aspects of geriatric medicine, outcomes are difficult to quantify. It can be really challenging. In the emergency department, we have a very short time span that we see patients. We have a very small opportunity so we can see associations, but it's very difficult to prove with rigid traditional evidence. Some of the things we're working on specifically right now is looking at patient-centered outcomes. What the positive impact of our work is having to patients, as well as looking at more traditional things such as cost effectiveness, lengths of stay, negative side effects, these sorts of things. But I think for a lot of frontline workers, it's a really big jump to make from doing good work to showing good work.
Yeah, and that's the core issue regarding health services research. We are not doing the bench research. We are doing research on your daily practices. And we can try to find out the beauty inside of your research, inside of your practice, to share with the others, so that all the world learn together. So we will also have 3 lectures regarding the global trend on age-friendly healthcare, regarding some innovative practice, and also regarding how do you design the research in your real field, and how do you collect data, and how do you analyze your data, both qualitatively or quantitatively. 所以这个是对各位做临床工作的人的研讨会，因为一般你们可能会听到一些是那种基础的研究啊，等等等，但是这个是说你在你的高龄友善健康服务当中，你如何，包括你事后可以把你的经验做一个分析整理，但是你也可以学到下次你事前就做一些设计，那这样你到时候以后要分析的时候得到的会更好。所以我想这个是为临床的人所设计的一个研讨会，就非常的欢迎大家来报名这样。So I do a marketing again. Thank you so much.
Yeah, I am. So use it, then you can.
And I think building on that, I think that's been one of our most successful things, is engaging everybody in research. So one of the key things we did at the very beginning, because we were committed to research from the front line right to the senior leadership wanted to see cost effectiveness things, because they want to say, if I say to them, I want you to invest more nursing time on this versus that, they want to see that we're getting the results. But at the front line, what we did was we borrowed a program from the NHS called Releasing Time to Care. And that allowed our frontline nurses in every single unit to be identifying things that mattered to them that they could actually change in the moment. So for example, every morning our nurses will huddle and they will take a look at their safety crosses, and they would choose the indicators on every unit. So for example, they would say, did anybody have a fall? Did we have a catheter-associated urinary, or did we have an inappropriate catheter in place? And by looking at that every day, prompted a conversation. What could we do different? And it was a no-blame kind of culture, and that got them engaged in quality improvement. On a quarterly basis, we would have our system-level data, some of that data that we would show, and we would again share that with the nurses, because the nurses and the rest of the doctors, they got energized when they would see, my goodness, what we're actually doing is making a massive difference. And as Dr. Ellis was saying, we haven't just focused on outcomes like cost effectiveness or infections or those sorts of things, but we've really looked at patient satisfaction and staff satisfaction as well. So the emergency department volunteer model she created, she doesn't know this, but it actually got funded permanently by the hospital. The hospital's investing in that money. In the program. Why? Because part of the research we did was not just looking at how many visits that the volunteers were doing, so we saw that they were busy seeing patients, but we asked all the nurses in the emergency department, does this release more time for you to do the direct care you need, and is this improving the care? And because our staff wellness is so important to us, our head of human resources funded the full-time program now, because this is actually helping to improve staff wellness, but also the patient experience. So, but if we don't collect that data, then we don't know those stories as well.
Okay, I think it's about time. But before we close this session, I would like to invite Dr. Wang, the Director General, if you have any comment to make for the ACE program.
Thanks for the speakers to come here and sharing the experience. Actually, as I visited Mount Sinai Hospital last year, then I found that is very important issue because we are, as Dr. Chu mentioned, that we are working with a age-friendly hospital for many age-friendly health service for many years. But I think that we still have some thing that we have to get improved. So this time, I think that the acute care or you call advanced care. I think these are good terms that the advanced care for elderly, even in the hospitals. You mentioned, but I think we have another conference 2 days later in the pre-conference, more time for sharing. Maybe it's a whole day, is that right? Yeah. And I noted that there are a lot of things that you want to share, but the time is really limited. So I do another marketing that you can come to the conference 2 days later. So maybe you can mention about that conference. I think that is a more comprehensive and more in detail and in-depth discussion about the care, advanced or acute care or advanced care for patients in the hospitals, in the emergency departments, in the communities, and also in the medical clinics. So just you're welcome, and we hope that if you have any questions, send your message to the HPA Health Promotion Administration. We are welcome to your questions or your suggestion that we can work together to find a new way of the acute care for elderly in the future. Thank you.
Thank you. So I will have to close this session, and thank you very much for all the fruitful comment and feedbacks. And I will do the last social marketing of my own conference tomorrow. No, there's another conference. There are so many in this week. Tomorrow will be the 5th Asian Conference for Frailty and Sarcopenia. So yes, anyway, if you have time. So if you have time, we're welcome to join that session. Then we're going to officially announce the 2019 Asian Consensus for Sarcopenia Diagnosis and Treatment. So I will have to close this session, and thank you very much all for all the participation and the active exchange. Thank you.
各位女士、各位先生，那我们的闭幕的典礼即将在我们5点半，在我们101的会议室。那所以请大家在5点前可以到我们101。Ladies and gentlemen, please join us in the close ceremony back in room 101 before 5:30. Thank you.
很漂亮。
哦，这样好。哎，你好，我是嘉里市医院，我有报名礼拜三的一个 A 那我想知道我有报名之后，我想要问他说你们穷人怎么照顾？我觉得好09154。
讲，反正我也不认识他，但是我一听他的报纸，我就觉得哇，差好多。我之前在那边工作3年，
老师你也去了？
在 Sporting Rehab，这是我研究所毕业之后的第2个。